Good morning, everyone. It is a huge pleasure and an honor to invite you and to welcome you to this unique, important and special event. It's important and it's special because it's the first event of its kind that we have organized in combination with charity Action for Pulmonary Fibrosis through the Brompton Hospital. It's also important and special because it's a special date. It's the 11th of November, and I'm sure I don't need to remind anyone of the significance of that important date. Now, I'm going to, in a second, introduce you to my two very important colleagues who've helped to organize this event. My name is Sujal Desai. I'm a consultant radiologist at the Royal Brompton Hospital. Two things I want to say before we start this day. First thing is, this day is about you, the patients, and it's extremely important that we all, as presenters and you as the audience, realize that this is a day about patients, carers, and their families. The second thing is I want to say is if you take away one thing from this day, I hope you will appreciate that this is a team effort. Putting this event together has been a total team effort, but also caring for patients with lung fibrosis is also about teamwork. Many of you see physicians. When you visit hospital, you see physiologists, you may meet people when you come for your scanning, but there is a big team behind the scenes. There are scientists, there are people like myself who you may not see, who sit in radiology offices and report scans, but there are many, many people who work together as a team to offer the care that we'd like to give to patients with lung fibrosis. So that's all I wanted to say. Welcome again. I'd like to now introduce you to Louise Wright, who has worked with us in putting up this event from Action for Pulmonary Fibrosis. Louise.
Oh, thanks, Sujal. What a lovely introduction. I'm Louise Wright, Chief Executive at Action for Pulmonary Fibrosis. And just to reiterate my thanks to both Pete and Sujal, who've been a driving force behind today, but to all our speakers and the team behind the scenes today. At APF, we really understand the devastating impact that it has to receive a pulmonary fibrosis diagnosis. And we know that COVID has compounded the difficulties in accessing timely information and support, but also those feelings of isolation and desperation. And that's why we're really delighted to be part of this event today. As Sujal said, you know, it's the first of its kind, and we hope the first of many to come. We've had nearly 200 questions submitted ahead of this event, and we've shared all your questions with our chairs today. We know that you'll have many more questions and comments as the day progresses, and we invite you to use the chat function as the day progresses. So unfortunately, we can't answer individual questions, but we will be keeping a close eye on your comments and we'll aim to answer them as we progress through the day. There's lots of support available for you and your family. Sign up to go and find the Action for Pulmonary Fibrosis website, actionforpf.org, and you can sign up to our e-newsletter and receive timely information and updates of support that's available. And you can follow the day today on Twitter. We'll be using the hashtag PF Patient Day 2021. And it's a great way to share the information with others and to raise awareness of PF. I've just been corrected that it's to use the Q&A function on your comments and questions today. I'm going to hand over to Pete, who's going to talk us through the rundown of today.
Thanks, Louise, and thank you to you for joining us for this day. It's I won't echo the words of Sujal and Louise, but I'm most proud about this day because the agenda, which I'll talk you through shortly, was designed by patients, and we hope that we've managed to hit all the important points. We hope that we're able to address the questions that you want addressed, and we do hope that this ends up being an informative and useful day. So we're going to start in a moment with a session which is entitled Different Forms of ILD and How They're Diagnosed. And Professor Wells will give us the first talk on a general approach to diagnosis, and we will then do a mock multidisciplinary team meeting, an example of how we sit as a group of clinicians, radiologists, pathologists to come to a diagnosis. I hope it's illuminating and insightful. We'll then have a session on treatment for ILD, which will be chaired by my colleague, Dr. Alex West. After that, a really important session on quality of life and ILD, and that, I'm really looking forward to that. And our final session, appropriately, is about the future and research. We're joined by speakers Marlies Wittenbeek from Rotterdam. Gisli Jenkins is dialing in from somewhere in the United States, if you can get the timings right. And we're really excited to hear about what is still to come in this field. So I think we're bang on cue now for Sujal to introduce Athol, and we'll start the day. So thank you.
Thank you, Peter. Before I introduce Athol, I'm going to say I'm going to be quite tough as a chairman. We are going to finish on time. But on that note, I mentioned at the beginning that this is a special day. At 11 o'clock, we are going to hold a minute's silence. And at that point, whatever is going on in the presentations, I will call it to a halt, and we will hold a minute's silence as part of this meeting. But with that, I'd like to introduce my friend, my mentor, my colleague, Professor Athol Wells. I've known him for 30 years. He has a huge brain. He has massive experience. He's a doyen of interstitial lung diseases, and I can think of no one better to kick this day off to tell patients about a general approach to the diagnosis of interstitial lung diseases. Professor Wells.
Thank you very much indeed, Sujal, and I've taken aboard that you will step in ruthlessly and stop me if I go over time. That's understood. I hope you can hear me clearly. Nod if you can, Sujal. And what I don't yet see on the screen is my slides, and I hope you take this into it. Thank you so much. So, despite this glowing introduction, what I have today is an entree to what really matters in this session, which is observing diagnosis and action. And I'm going to lead into this once I'm able to control my slides with a few thoughts which I hope provide a framework for diagnosis and action that follows. So why do we make an exact diagnosis, actually? What is the real practical value of that? Well, with an exact diagnosis, we know the likely course and outcome without treatment. We know the likely course and outcome with treatment. So we can balance the risk and benefit of treatment. We know what treatments to use. We know what treatment goals are logical, and we know how we should monitor to see that the goals are achieved. And I have to say at the start that in this field, we are beset by jargon. We have a huge number of individual disorders, and I think you'll agree that such terms as idiopathic pleuroparenchymal fibroelastosis and bronchiolitis obliterans organizing pneumonia are hugely unfriendly. You don't, from the terms, have any understanding of the disorders being labeled, and the jargon is off-putting. Most doctors outside the field don't understand the terms. So firstly, the same treatment goal and individual treatments cover different disorders. And in some disorders, different individuals have very different behaviors of their disease. And so I'm going to say from the start, forget the complexity, but with an exact diagnosis, what matters is not the label, but the knowledge of what is likely to happen with and without treatment. This allows the doctor to know what to say about the disease and what to do about the disease. And I think to underpin this, we can think about what we should do with treatment goals in any disease. It doesn't matter if we're talking about interstitial lung disease other types of lung disease or other diseases. We can leave a disease alone if it is limited, and it's likely to get better, especially if you can find a trigger and remove the trigger. We can leave a disease alone because it is past history, it's been active, it's left behind a footprint, if you like, perhaps limited scar tissue that you can't remove, but it's past history. If we can't do that, we can try to remove the disease or remove some of it. If we can't do that, we can try to prevent it from getting worse. And if we can't do that, we can try to slow it down. So our very complex diagnoses are really channeled into what are you going to do about it. And in recognition of this, let's suppose that a diagnosis of idiopathic pulmonary fibrosis is made. Now, what you then know for that disease, there is a logical treatment goal, and the other potential treatment goals don't apply. From the outset, this is an illness where we are trying to slow disease down, and as you know, I suspect, there have been huge advances in recent years with often highly successful slowing down of the worsening of IPF. And I won't dwell on this, but just so you know, this pattern of what can you do about it is applicable across all our diagnoses. So we're really making diagnoses in order to place what are you going to do about it and how are you going to monitor it. We're doing that to fit that to the diagnosis. So I wanted to get through what might be called the philosophy of diagnosis in less than half my time. And I think I've managed to achieve that. So now I'm going to take you through the actual process. What does a clinician do? And how is that integrated within the team that Sujal has so eloquently referred to? So obviously you start by talking. And here you're trying to identify whether there is something that is driving a disease. We can call this triggers. You are looking at the environment, and some of you will have been interrogated to the nth degree on home triggers of hypersensitivity pneumonitis. We are searching out symptoms that suggest that you might have a form of loss of immune balance, what we might call autoimmune illness, that hasn't necessarily been diagnosed. It's surprising how often we find this, actually. And we are considering occupational exposures, so where you've worked perhaps before you've retired, perhaps over decades. And finally, with triggers, we are thinking about drugs for other diseases that might cause lung disease. And believe it or not, if you go online, you will find up to 150 different drugs, increasing year by year, known to cause interstitial lung disease. It is helpful to know if there is a family history of pulmonary fibrosis. This doesn't mean you're programmed always to get pulmonary fibrosis, but likelihoods change if there is an illness that runs in the family. And then sometimes you've got to find disorders. I've talked about looking for hidden autoimmune illness, but you are going to be talking about all of your illnesses, all of your drug treatments because of drug-induced disease, to determine whether there might be additional diseases driving the problem. Physical examination used to be crucial, and ideally, physical examination should still be performed because this occasionally does influence what is likely in the diagnosis, but less than you might think. And that's just as well these days because with COVID, quite often we're limited to remote consultations. I've yet to hear crackles in the lungs by video. And often a referral letter from a doctor who has examined is very helpful. But on average, the history, the initial discussion, gives the clinician 90% of the diagnostic information. Before CT came along, the physical examination was often crucial, but with CT, that's no longer the case. And then there are general blood tests in order to know about other disorders. There are screening blood tests, most often to find hidden autoimmune illness, and then more detailed blood tests that will be done because when you talk about your situation, there is something that comes up that drives you to do the tests. So you might move from general autoimmune tests that are limited to a very full panel across the whole range of possibility. And then the CT, well, you're going to see examples of CT in the next group discussion. But I would say that in general, what you do with talking and a degree of examination and some blood tests and the CT give you 50-50 contributions to what you can then conclude. And you know, sometimes CT is conclusive and the clinical evaluation isn't. Sometimes it's the other way around. But you mustn't over-rely on the scan and blind yourself to a proper discussion of the history. You know, if you look at a scan, you're convinced by the scan, and you can blind yourself to a proper elicitation of what might be driving the disease. Lung function tests you have very rarely change diagnostic likelihoods, but they're generally done to measure severity and allow the disease to be monitored. Now, at the end of all this, and I see I have 4 minutes before Sujal will chop me off at the knees. At the end of all of this, the information is discussed in a multidisciplinary meeting. You're going to see this in action. And sometimes the diagnosis is definite at that point, and sometimes further tests should be done. Perhaps a bronchoscopy, perhaps a biopsy procedure. But the question is, if you can't get there to 95%, which around the world is viewed as definite, believe it or not, can you make a working diagnosis to guide treatment? And I see this has not projected very well for some reason, probably because the format has been standardized in transfer. But basically, there's agreement that when you discuss all of the information, so that's a multidisciplinary diagnosis, the diagnosis can be definite, it can be provisional. So a working diagnosis made with high confidence or with lower confidence. But if you can't come up with a first choice diagnosis that is more likely than not, so above 50%, then you have to say the disease is unclassifiable. Now, I'm going to give you a brief metaphor here for what happens when we pull together the information. And I'm referring first of all to Alice in Wonderland and the Cheshire Cat. If you don't know where you are going, any road will get you there. And multidisciplinary diagnosis is very like the Cheshire Cat, who you may remember disappears and appears. Sometimes a diagnosis is definite, it's established, and you can see the cat completely. Sometimes a diagnosis is provisional. So in other words, you are able to manage on the basis of the diagnosis. And sometimes disease is unclassifiable. And often the key decision is whether to perform a biopsy. This isn't straightforward because biopsies carry risks, but sometimes lack of information is more dangerous. Certainly biopsy is often too dangerous, especially in older people or when lung disease is severe or there is cardiac disease or alternative disorders. 2 final points. I mentioned unclassifiable disease, and the whole point of taking you through this is that you understand that diagnoses change. If a diagnosis is 70% likely, then there's a fair chance that it will have to be revised with time. These are the breakdowns of the key disorders I hope you can see that with this transfer of format. What I want to draw to your attention is that close to 20% of patients who don't have IPF have disease that is unclassifiable. This is a very large and reliable international compendium. And finally, I'd like to give you this metaphor for what exactly we're doing when we diagnose. So, you know the Hindu legend of the three blind men and the elephant. And in diagnosis, we have three blind men, each of us examining a different part of the diagnosis. So the clinician, the pathologist, and this is an artist's impression of Professor Desai as a radiologist contributing to the diagnosis. So in summary, an exact diagnosis is hugely desirable, key information as to how disease will behave with and without therapy. It must be meticulous, but you have to accept that with state-of-the-art diagnosis, there will be uncertainties, but there will almost always be a sensible treatment approach that covers the diagnostic possibilities. Professor Desai is about to stop me, so I will stop myself.
Athol, that was, as expected, masterful. Thank you so much. A very clear depiction of how we manage patients, diagnose patients, and the difficulties we face. And I think the next session will bring all of this to life, because as Pete said, we are now going to sort of simulate an MDT. This is something that we do every week. MDTs are now part of the pattern of care in the NHS. All cases, not just pulmonary fibrosis, are discussed in this way, where experts with different specialities, these blind men that Athol spoke about, come together and review cases. So with that, what I'm going to do is, this is going to be a sort of double act between myself and Pete. Pete is going to introduce the clinical aspects and going to ask questions. I'm going to show the imaging to my colleague, Professor Devaraj, and will hopefully show you how cases are discussed at our MDT. Pete.
Perfect. Thanks, Sujal. Athol, Anand, and Andrew, can I ask you to put your cameras on? Perfect. Perfect. So this is going to be an example of our multidisciplinary team meeting, what we call the MDT. And you've met Sujal and myself. We've got at this meeting Professor Anand Devaraj, who's another one of our professors of thoracic radiology and an expert in ILD imaging. Athol Wells, who you've now met and is, as Sujal says, really our clinical forefather in this field. And Andrew Nicholson, who is probably the most famous pathologist in the field of interstitial lung disease, at least in his own house. Truly one of the most famous, published and really brought this field forward over the last 20 years in a way which has allowed us to understand more about how these diseases behave and how to diagnose them. So I'm going to grill our panelists now, and we will try to keep the language cleaner than it normally is when we have our meeting. Of course, it's always robust discussion, but with the utmost of respect for one another. And I hope that you get to see that today. So our first case, and Athol, you can unmute if you don't mind. Andrew, please unmute, because we may ask you to come in at various times. Our first case is, and these are real cases, is a patient who we look after at the Brompton, and it's a 67-year-old man who has been breathless for the past 2 to 3 years. He has a cough. He was diagnosed with COPD, chronic obstructive pulmonary disease, for a couple of years before he came to us, which unfortunately is so often the case, and delayed diagnosis is an area we really consider to be important. He has no relevant exposures, and by that we mean, as Athol mentioned, he's not exposed to anything in the atmosphere or any drugs which might be relevant when thinking about fibrosis. And he has no CTD features. That means no connective tissue disease features. There's nothing in the history which makes us think that he might have some kind of immune problem driving his lung fibrosis. And the serology, which is the blood tests that we do when we assess patients for the first time, was completely clear. There was no suggestion of any problems with the immune system, and nothing in the blood test that suggested that he might own a parrot in his garden that might be relevant to a lung condition, and no mold in his house that we think might be relevant in terms of the blood test. So Athol, I'd like you, if you don't mind, would you be able to talk us through what these things mean? This is the lung function test. Very briefly, what does this mean, and how do you interpret this?
Well, I think looking overall that this is a moderately severe problem. With lung function tests, we are measuring both the ability to bring air in and out of the lung and the way in which the air is handled to extract oxygen. Now, this man has no difficulty breathing in and out, and there are measurements here that are in what is called the normal range, which is 80 to 120% of what is predicted. So when you first look at the lung function, you might superficially think that there isn't a problem. But when you look at the thing called Dlco, the second to bottom measurement, that is a measure of the whole function of the lungs, and that's down at 37% of normal. So on a scale of 1 to 5 for badness, accepting that 80% is the lower limit of normal, I would say that this is somewhere between 3 and 4 out of 5 for the severity of the problem. I could say more. It will be technical. I may come back to this as we discuss the case.
Yeah, we may need you to. Athol, would you expect a patient with lung function like this to be symptomatic, to be breathless?
I would generally, because generally people are breathless unless their illness moves very slowly. It's amazing how something developing over decades, you can adjust. But for the disorders we look at, by the time the efficiency of the lungs is down to roughly 5%, people usually know about it.
So I think what we're saying here is the Dlco, which is the efficiency of the lung, the ability to extract and use oxygen in a useful way is a major issue here.
Yeah, I think the Dlco captures everything about the lungs. In fact, it sums everything up. And what that tells us is that there is some impairment in lung function across the various ways in which the lungs function, which is really quite severe. So I think that's the best summary.
That's very helpful. And I guess the final point before we move on here is that if a patient was simply to have spirometry, which is the lung function test that sometimes you can get at your GP practice, you may be falsely reassured that there's no problem with the lungs because those are the top 2 or 3 figures. But actually you need a detailed assessment of the lungs with more technical lung function tests that you can only really have in a hospital setting.
Yes, that's correct. Those measures would be said to be completely normal.
Okay, thank you, Athol. The next is the imaging. So we're going to drop to Sujal, and Anand is going to very kindly walk through the imaging, and Sujal is going to make his life a bit uncomfortable.
Okay, so let me just switch to the images. This is the CT scan, which stands for computed tomography. This is a specialized X-ray machine which takes images around the patient. So unlike an ordinary X-ray, which is essentially a 2-dimensional presentation of 3-dimensional anatomy, CT gives us that much more information. And that's why many patients who have either a suspected or an established lung disease will be referred for a CT scan. So I'm now just scrolling through, and my colleague, Professor Devaraj, is looking with beady eyes and his experienced eyes at what the CT scan shows, and he's concentrating on the patterns and the distribution of disease. So Anand, can I ask you to make some initial comments and talk about how you interpret a scan like this?
Okay, thanks very much, Sujal. So what I'll do is explain how I approach looking at the scan. I'll then describe what I see. If I use any medical terminology, I'll follow it up with an explanation of what I mean by that. So the very beginning, it may seem obvious, but the first thing one wants to do is to understand whether the scan is normal or abnormal. Because if the scan is normal, of course, then there's not much more to say. Now, at the very beginning, I can say that this scan is abnormal. So why is that? Well, I'll be explaining a bit more about this in a talk I'm doing later this afternoon, but the normal appearances of the lung are essentially black. So
are you talking about areas like this?
That's right. So that is air or gas within the lungs that has an appearance that looks black on the CT scan. And of course, in between all of that, you've got blood vessels and airways.
So these are these structures, the vessels and airways here. Yeah.
Yeah. So that's part of normal anatomy. But the area that I'm drawn to straight away that is abnormal is near the edge of the lungs. So that's right. So you can see there that that's not as black as the rest of the normal lung. In fact, it's slightly grey or white, and that is abnormal. So once I've established that the scan is abnormal, the next thing is to characterize what the abnormality is. And for patients with interstitial lung disease, a very important first question that we have to ask is there lung fibrosis? Is there scarring? And what we do is look for specific clues that tell us that there is fibrosis. In this case, on the slice that you've got there is very much evidence of fibrosis. So what we look for is something called traction bronchiectasis. Now, that's a medical term, but what that means is that the airways, which are, as I said earlier, are normal anatomy in your lung. As you breathe in through the windpipe, it then branches into what are called bronchi, into your lungs. Those are the airways. But they get smaller and smaller normally as they get to the edge of the lung. But what you can see here is that actually those airways are quite large. And the reason for that is because the fibrosis next to the airways in the lung is pulling apart the airways, dilating them, expanding them, if you like. And that is an abnormality which we know in radiology is an indicator of lung fibrosis. So immediately I can say that this is a scan shows quite extensive lung fibrosis, because the abnormality is not just at those bases, but as you scroll up and down the scan, and what that means when I say scroll up and down the scan is you're going from the bottom of the lungs to the top of the lungs and back down again. That's the top of the lungs up there. And as we come down, we'll go to the bottom of the lungs where the diaphragm is. You can see that there are quite a lot of these white or grey areas that signify fibrosis.
Yeah. Okay. And is there anything at this stage, would you be able to offer in your report? What would you suggest to be, this has been referred by Professor Wells, and he says, look, I think there's lung fibrosis, but I want to know a bit more detail. And you've described the signs. What would you put in your conclusion of your report as to what you think might be going on? That may not be the final diagnosis, but what you think is going on.
So CT offers the opportunity not just to demonstrate that whether there is lung fibrosis or not, but also the opportunity to characterize or categorize the type of fibrosis, because as has been mentioned before, and as many patients will know, there are lots of different types of fibrotic lung disease, some called idiopathic pulmonary fibrosis, some called hypersensitivity pneumonitis, all these different conditions which are different types of lung fibrosis conditions. And the CT can often give you clues as to which of those types you're dealing with. So in this case, as we scroll to the bottom of the lungs, what I can see here are two things. First of all, what we call reticular opacities, which are little lines, short.
Sort of crisscrossing lines, isn't it? I think it comes from the word net-like. So we look for these, yeah, sorry. Yeah,
absolutely. And there's some on the right as well. And then also something that we call ground glass, which is basically grey lung. So in addition to lots of small linear straight lines, which are white, we also have a sort of smudging, if you like, for want of a better word, of grey appearances.
Yeah.
And that is that tells me that we may be dealing with one of two types of conditions, either what we call a UIP pattern, which often goes with idiopathic pulmonary fibrosis, or an NSIP pattern, which often goes with connective tissue diseases like scleroderma or rheumatoid arthritis, where patients can also get fibrosis.
And we've heard here that there's no, as Peter said, there's no suggestion of a connective tissue disease. So probably you'd go down the other route, wouldn't you? Because you'd have Professor Wells saying, no, but I want to know what you think it is, as he says every week to us at the meeting. And you would say this is more like a UIP pattern.
That's right. I would favour this being idiopathic pulmonary fibrosis due to what we call in radiology a UIP pattern.
Okay.
Sujal, do you want to drop to the clinical slides?
Yep. So I'll stop sharing and then we'll go back to the clinical slides.
So we thought in the meeting that it looked a lot like it might be idiopathic pulmonary fibrosis, but there was sufficient diagnostic uncertainty when, as Anand says, there was these changes that looked like ground glass change, a bit of greyness to the lung, such that we felt it was important to go on to do a bronchoscopy. So Athol, if you wouldn't mind just describing what a bronchoscopy does, and then Andrew, if I could ask you then to tell us what we look for in a bronchoscopic sample.
Okay, so a bronchoscopy, as many of you know from experience, involves placing a tube, pushing fluid in and out of a segment of the lungs and looking at the content of the fluid. And the content of the fluid can sometimes shift the likelihoods of diagnosis. There is a certain profile associated with certain illnesses. And I think to be more technical than that would be to go over the top. But essentially, we are looking to see, in this case, whether there is a profile of inflammatory cells in the fluid that would make you doubt the diagnosis of idiopathic pulmonary fibrosis.
Thank you, Athol. And to just provide a bit more detail, it's a day case procedure which is done with a little bit of local anaesthetic and sedation, but on the whole, the patient is able to go home after a few hours, and it's reasonably well tolerated, although uncomfortable, undoubtedly, but reasonably well tolerated and safe. And so, Andrew, if you, what do you do with the fluid that we send you, and what do you think about these results?
Well, the fluid comes down in a pot, usually the same day as you've taken it out of the lungs, and we would spin this down and then take a sample from the sort of more cellular fluid at the bottom and put a little bit of that on a slide. And then we do what's called a differential count. So a differential count is basically, you can see second row on the right, it says total cells 300. There are several thousand cells on a slide, but we would pick what we think is a representative area or two, and we would count that number of cells, and basically in the middle column you can see there is a percentage number of macrophages, lymphocytes, neutrophils, eosinophils, and mast cells, and these are all the inflammatory cells that your body has within them, and also get extravasated or get out into the alveolar spaces in the lungs. And you can see from this particular one that the neutrophils, the third one down, is raised. The lymphocytes are borderline. The eosinophils are slightly up. That in itself, I don't think it's abnormal. It's not hugely specific for any one disease, but it argues against some diseases in that sarcoidosis or a florid or cellular hypersensitivity pneumonitis would have a raised lymphocytosis. A mild neutrophilia and a borderline eosinophilia would be consistent with idiopathic pulmonary fibrosis, but I think it's sort of sitting in a kind of, I suppose, a mid-range for that. So I think it argues against certain diagnoses, but it doesn't push you towards any particular one. The only other thing I would add is that some of this fluid also always goes to microbiology, as there is a differential diagnosis sometimes of infection or indeed superimposed infection. And if we do see organisms in a lavage, we can look for them in our laboratory as well.
Thank you. That's really helpful, Andrew. Thank you. So Athol, this is your patient. And you would, in an ideal world, be walking us through this. What are you thinking, and how would you try and bring the team together to make a diagnosis on the basis of the investigations you have so far?
Well, at this stage, before the bronchoscopy, I guess that I was thinking in terms of idiopathic pulmonary fibrosis with a high likelihood, but not definite. So somewhere between 70 and 90% likely. I would be arguing that the bronchoscopy was done to look at alternative possibilities. And I do not see support from the bronchoscopy from one of the two alternative possibilities, which was a condition called hypersensitivity pneumonitis. It could still be that disorder, but the likelihood is just diminished to a fair degree. The second possibility I was looking at is an alternative form of fibrosis, possibly with an autoimmune flavor. There was something on the lung function I didn't discuss that made me consider that. And I think that is still there as a possibility. But I would say that if you started with the sense that idiopathic pulmonary fibrosis was perhaps 80% likely, it's gone up on the basis of the bronchoscopy, and you're touching a definite diagnosis. So I would say at this stage, we're going to see blood tests, I suppose. We're going to see if there was any evidence. Well, you said there was no evidence of an autoimmune problem.
There was not.
So I'm saying that this case now is close to definite for idiopathic pulmonary fibrosis, close to definite. And we would be discussing whether it is appropriate to simply manage the problem with that diagnosis, close to 90% likely, or whether a further test should be done. And I won't say what I would say because it would be for the meeting to make that judgment.
Correct. So I think when we discussed this case at our meeting, we didn't feel that a biopsy would be helpful here. We also didn't feel that it would be safe with a patient who has a gas transfer of under 40% because the risks, as we know, go up. And given the combined confidence of the radiology team, the pathologist and the clinician, we came to a diagnosis of idiopathic pulmonary fibrosis. I think we should move on to the second case because I do want to get to that. It's an important one, but this is just a flavour of how we managed to get to a diagnosis as a team and build upon at each level of confidence as we get more and more information together. The second case is a 70-year-old man who's been breathless for 1 year. He was a builder and was exposed to asbestos for 10 years, and he's got this thing called Rayno syndrome, where there is a discoloration of the fingertips. It's to do with an abnormality of the blood vessels and the periphery of the fingers and can be associated with some autoimmune conditions. But he did not have any other features of any autoimmune conditions. And actually his blood tests did not suggest that he had rheumatoid arthritis or anything else. There was just a suggestion, aspergillus is a type of mold. There was a suggestion that he may have been exposed to mold at some time in his life. But when we asked him in more detail, that didn't become particularly apparent. Athol, quick thoughts about the lung function tests?
Well, it's a parallel set of comments. The tests you would have in a GP surgery are in the normal range. They're right at the bottom of the normal range. That's the top 3 tests, by the way. They're right at the bottom of the normal range. That might cause an astute doctor to wonder if there is a problem. But truth again lies with the Dlco, which is at 50% predicted. And that's a category 2 out of 5 for badness. that's a category 2. So there's an unequivocal problem there based on the lung function tests.
Agree. Okay, so the imaging, Sujal.
Okay, if I can just share the screen. Okay, so let me just get the second case on the screen. And let me just minimize this. And it's this case. So I'm going to do the same thing. I'm going to scroll again, and I'm going to ask Professor Devaraj to make some comments. So Anand.
Okay. So I'll just wait until we've gone from the top to the bottom. All right, so again, using the same approach that I used before, the first thing I can say is that this is an abnormal scan because there are areas which should be black but are not. That is an indicator of abnormality. Now, in this case, the abnormality is slightly different to the previous case. One of the first things that I will comment on is about the pleura. Now, the pleura is the lining of the lung, which is normally very thin and sort of covers the lung, and you can sometimes see it as a very thin stripe on a CT. But in this case, what you're seeing is actually the pleura is quite thick and widened. That means that there's a disease process in this case that has affected not just the lungs, but also the lining of the lungs. And we know that there are some diseases that do that. And I believe you mentioned in the history that there was exposure to asbestos in the past, and asbestos exposure is one of the diseases that cause both abnormality in the pleura and can also sometimes cause lung fibrosis. So that's the first observation. The next thing, let's move on to the lungs itself. Now, again, there is some evidence of fibrosis. That thing I mentioned before, traction bronchiectasis, dilated, enlarged airways, because of the fact that the fibrosis is pulling apart the airways. We can see one or two areas like that. So this disease, this abnormality is affecting both the pleura, i.e. the lining of the lung, and is causing fibrosis. And so I might be thinking about pulmonary fibrosis related to asbestos here. It's also possible, of course, because asbestos exposure was relatively common in the past, that it's also possible that you may have pulmonary fibrosis due to another cause, and the pleura thickening is incidental and almost like a bystander and not really relevant. So that's also something that the clinicians will need to consider.
Do you think, Anand, you'd be in a position to give us a first choice diagnosis, or would you in the MDT be asking for a bit more information here?
Yeah, so I think if we leave aside the pleura for a moment, the actual fibrosis is not that specific here. It's quite limited. It doesn't have the clear-cut clues that we look for to say, oh, it's definitely this pattern or definitely that, or it's definitely hypersensitivity pneumonitis. It's quite limited, and I would say a phrase that we sometimes use is an indeterminate fibrosic lung disease, which is saying we can tell that it's fibrosis, but we can't take it any further.
And this is a situation we do face every week at our MDT, don't we? Where the radiology is non-specific, as Anand says. The clinical features, they are telling us something is wrong with the lung function, but we find it difficult. This is where the discussion really sort of takes off and comes into its own.
And
Sorry,
I think it's important, we can get the clinical slides back up. I think it's important to appreciate that at stages it can be difficult for us to come up with a first choice diagnosis, and that shouldn't be stressful for patients, because it just means we are working through the process and trying to gather more information until we can, as a group, come up with the most likely diagnosis that informs treatment and prognosis. So Athol, what would you do next here?
I would do a bronchoscopy, I think, possibly with a cryobiopsy.
Well,
we'll talk about the bronchoscopy, therefore.
So what do you think, Athol?
There is a striking increase in the lymphocyte count. There are also signs that often go with fibrosis, but are a little non-specific in that the neutrophils and to a lesser degree the eosinophils are increased.
Athol, you're looking at this middle column, aren't you? Just for the patients.
Yes.
The 37 is the lymphocytes, and then the neutrophils 25. That's the middle column you're looking at. Yeah. Okay.
I'm just making sure that I'm reading this correctly. I want to see the percentages, and I am reading it correctly. So the lymphocyte percentage of 37 is very high. And when you see that, you are immediately suspicious of hypersensitivity pneumonitis, so something environmental driving this. There are some other causes that might be present, but I think that alone at that level in this setting makes you suspicious of that. And sometimes the pleural abnormalities can go with a disorder like hypersensitivity pneumonitis. I'm not saying this is diagnostic, but it's giving us a very strong lead. And I think the issue here would be whether to then proceed to further testing.
But Athol, are you not bothered by the fact that the patient doesn't have any exposures, anything that in his house or his work, which might give you that confidence in a diagnosis of hypersensitivity?
I'm not saying I've made a definite diagnosis here. I'm saying the likelihood has shifted. Now, around the world, in those people that have biopsy proving hypersensitivity pneumonitis, so something driving this, a third or more have nothing you can identify in the environment. So this scenario is not uncommon. It may sound highly unsatisfactory, but it is the fact of the matter.
So that's right, Athol. I think the point is that sometimes patients and clinicians spend a lot of time and money in trying to rip up their home, find explanations, find causes, and really we should advise them that in a large number of cases, there is no identifiable cause. Athol, we'll pass to Andrew in a moment, but can you just explain what a cryobiopsy is?
Yes, when you come to bronchoscopy, you are able to advance a probe beyond the tip of the tube you've inserted. It's a very thin probe, so it can slide down small airways without having to be forced in any way. And you can carry the tip of this towards the edge of the lung. And then there is a freezing process around the tip of this probe, which attaches tissue in a circle around the tip of the probe. You can then withdraw the probe and you've got your biopsy specimen. The plus is that the risks associated with this test are hugely lower than the risks associated with a surgical biopsy. The risks do include a risk of leakage from the lung, but this provides often invaluable extra information. That's all I really want to say about this.
We've only got a couple of minutes before we're going to move to the minute silence, and then we can pick up afterwards. Andrew, do you just want to talk us through what we can see here?
So Ray, you asked me to limit to 2 minutes, Pete. The top left shows a very low power of this cryobiopsy. Cryobiopsies give you a lot more tissue than transbronchial biopsies, which is just taking a little bite, but are smaller than the surgical biopsies. But nevertheless, you can diagnose quite a lot of diseases on them. And in the bottom left one, you can see there is some fibrous scarring. And the blue sort of lining is respiratory epithelium, which we call metaplasia. More importantly, in the top right, there's a small granuloma right in the middle, which is a collection of histiocytes which are reacting to whatever the immune insult is present. And then down the bottom right, you can see there is some fibrous scarring, again around an airway. So that combination of what we call bronchocentricity, i.e. the disease seems to be centered on the airways, plus a small granuloma, is strongly suggestive of what we call hypersensitivity pneumonitis.
Athol, has that clinched the diagnosis for the MDT?
It has, in my view. There's enough there because the cryobiopsy and independently the fluid showing that high lymphocyte count, if you took either of those in isolation, you are not as secure as you would be with the two together. So at this stage, I would say that you do have a diagnosis of hypersensitivity pneumonitis with scarring.
I think that's right. Sujal, I'll pass to you. I think we're not far off the
Yeah, we've. I'm studiously looking at my watch. We have about 25 seconds. I'm just going to ask very quickly, Anand, did the CT on that CT, unless we knew all this further information, would you have made a diagnosis of hypersensitivity pneumonitis on that CT scan?
On that last one, no, I think the features are indeterminate. Sometimes we can make a definitive diagnosis on the scan because the appearances are very classical for hypersensitivity, but in this case, it was very much a case of not being able to say with certainty.
Yeah, okay. So we've got a few seconds to go, and I just say I hope that has shown you the complexity that's involved. And now I'm going to ask for a minute's silence from now. So thank you, everyone, for keeping that minute's silence. I'd like to thank all the panelists. They've been absolutely excellent in that panel discussion, and also to Athol for that wonderful first lecture. Now, as Louise said, we have some questions that were submitted prior to this meeting, and I've sort of tried to summarize these various questions. And obviously, we can't ask every single question, but there are various themes that go through. So one of the questions or set of questions is based on rheumatoid arthritis, so a common connective tissue disease, and we know that in patients with connective tissue diseases, and in particular rheumatoid, we can get interstitial lung disease. So one of the questions is centered on rheumatoid arthritis and having rheumatoid arthritis. How does rheumatoid affect the lungs? What symptoms should patients expect? And how do they know that it's getting worse other than just symptoms? How do we monitor? So Athol, do you want to make some general comments about rheumatoid arthritis?
Yes, so in rheumatoid arthritis, in perhaps 10% of people, possibly a little more, there is significant scarring in the lungs, either early in the illness or developing downstream. And the reason for this happening has not entirely been teased out, but in general, if your immune system is hyperstimulated in a series of autoimmune disorders, including rheumatoid, it is more likely that some other factor that comes along will provoke an exaggerated response. And be that as it may, this is the risk. Now, the symptoms are the symptoms of interstitial lung disease in general, and the cardinal symptom is being breathless on exertion. Now, some of us are breathless on exertion anyway. Climbing 2 flights of stairs is my exercise, but I'm talking about a sense of breathlessness that is undue, beyond what you would expect from your usual limitation to exercise. And it can be difficult because with rheumatoid arthritis and the joints playing up, it can be incredibly hard work to walk. You can be breathless because of the joints. But if you have breathlessness that is undue, you should always ask the question why that is. Now, you might have cough. You might even just occasionally have wheeze, but these are not really very common things that bring the problem of lung involvement in rheumatoid to light. And then the question is about monitoring. And monitoring in rheumatoid is the same as monitoring across all of our diseases. It's again 3 blind men looking at different aspects. You look at change in symptoms, you look at change in lung function, and you look at change in imaging. And you have to put them together and work out, first of all, is the worsening, or perhaps improvement with certain treatments. And secondly, if there is, in fact, how much improvement or decline is there? But it's very difficult to do this with symptoms alone, especially if you're bedeviled by joint problems that affect how breathless you are when you walk.
Yeah. Okay. I wonder if I can put another question to Pete, actually, with your clinical hat on. Patients are obviously very concerned about a diagnosis of pulmonary fibrosis, and one of the issues, obviously, is how is survival, to put it bluntly. And what discussions do you have, and how do you explain to patients how that potent question: how long will I survive? And what's your answer to that type of question?
It's a really important question. It's probably the question that is most important and at the front of patients' minds when they first are diagnosed with a condition such as idiopathic pulmonary fibrosis. And I think the first thing to say is that I would urge patients to seek information from well-accredited sources. So, for example, Action for Pulmonary Fibrosis has a huge number of resources for patients to address those questions, the British Lung Foundation and the individual clinical teams, because that question is difficult to answer when patients present at different stages of their condition. Now, there is historic data which is frequently sought online using figures such as 3 to 5 years from diagnosis. That is old data now and doesn't necessarily take into account the impact of antifibrotic therapy, which we know has improved outcomes and life expectancy, and also the fact that the increasing awareness of this condition means that we are diagnosing it at an earlier stage. And so that means we hope that whereas previously patients spent 2 to 3 years as being diagnosed with possibly heart failure or asthma or COPD, they are accessing specialist centres at an earlier stage so that we are able to intervene with therapies that we know can preserve lung function and extend life. And while that sounds like a cryptic answer, and often it's hard to give a defined number of years, I would say that the outcomes and the outlooks now are immeasurably brighter than they were some years ago. I mean, Athol, would you add anything to that?
I think I would, because often people really are looking for precision, and you have to be very honest about it. The trouble is that what you say really suits some people and not others in the way you say it. And I've struggled to find the right way to say this for decades. I think on average it runs something like this, though. You can't be exact, but there is such a thing as good luck, average luck, and bad luck. And I think it is possible to sit somebody down and say, look, you have this range of possibility with what you have, how severe this is, the nature of the illness. If you have good luck, then this is the sort of outcome you might see. On average, you might see that, but you may have bad luck. And I think that tells people that they do have to confront uncertainty. There isn't a soft answer for a number of years, but you can give people genuine and justified hope if they have a better than average outcome. I can't be more exact than that, but I feel people are demanding something along those lines when they want to ask you, how long have I got?
And Athol and Pete, is it fair to say, because we sometimes, and Andrew, will see the same pattern, for example, UIP pattern, you'll see it in the context of rheumatoid, and we'll see a UIP pattern in the context of IPF. Is it fair to say that your outcome differs based on whether you have a rheumatoid-based same pattern as opposed to an IPF pattern?
There will be some differences, but I think the greater differences are within an illness of particular individuals. How is the disease behaving in that individual? That's why you have this range of good luck, average luck, and bad luck. And certainly if you look at how disease is changing over 6 to 12 months, you can start to tell people a lot more about what is likely to happen.
So it's going back to your disease behavior, isn't it?
How the illness is actually behaving in somebody. Yeah. It is a very major source of variation. So to try to actually capture this the first time you see somebody and make a diagnosis, the danger is you'll be heavily misleading.
Yeah.
You're giving this average.
And that, Sujal, if I may, just very quickly, is when we meet a patient for the very first time, not only do we have no information about trajectory, and of course that comes with repeated lung function tests, but also we're unsure of whether that patient will be in the category that responds very well to the antifibrotic therapies, and some patients do respond better than others. So when we're being a little bit unclear, it's because actually we don't yet have the research tools or the clinical tools to make predictions from first diagnosis.
Okay. There are some questions about hypersensitivity pneumonitis, which we've talked about today, and also sarcoidosis. Now, all of these conditions we know can cause fibrosis. There are some questions around the causes of sarcoid. Now, I think it's fair to say that even now, even though sarcoid was first described in the 19th century, we still have no clue as to the likely cause of sarcoidosis. Any views on whether we will ever find out, Athol?
Well, I think we do have clues as to what is going on. So there is a form of loss of balance of the immune system, leading potentially to damage in the lungs. What we don't know is the particular thing that triggers the loss of balance of the immune system. And in fact, we suspect that in many different people with many different makeups, different triggers come along and trigger this. So when we say we don't know the cause, well, it's questionable whether there is a single cause, but I think we have a fair idea as to what is going on. The trouble is, once this problem is triggered, it's not clear that it really matters what it was that triggered it once you have the entity of sarcoid. But as you're well aware, there's this debate, is sarcoidosis one illness, or is it several different illnesses under the same name?
And I think it's also fair to say there are times when we see patients with sarcoidosis who've got lung fibrosis, but they don't seem to, in terms of symptoms, have as bad symptoms as patients with IPF with a similar extent of fibrosis have. Is that true to say? I mean, that's one of the markers that I often use when I look at a scan and I think it's sarcoid, but I'm not sure. And you or Pete would come back and say, but the patient's hardly got any symptoms. When I get that combination, I often think, well, this is sarcoid, because patients don't often have that many symptoms.
Well, that's correct, Sujal, because many patients who develop sarcoidosis, it does either switch off with time, quite clearly. So you will take a hit and you will be left with a hit, i.e. what we're calling fibrosis.
Yep.
Or else treatment, which tends to be more effective on average than in other disorders. So if you're properly treated with sarcoid, you have to be unlucky to get worsening in spite of treatment. What that effectively means is that patients often don't get severe enough damage, i.e. fibrosis, they're experiencing major symptoms. Furthermore, sarcoid often has things about it outside the lungs, like sweats, fevers, joint pains. People get diagnosed sooner with sarcoidosis than with other disorders on average.
Right. And that probably a final question now. It sort of leads into some questions that have been asked about hypersensitivity pneumonitis. Can we stop it? Can we cure it? You know, questions that patients are concerned about. Any views on how, when you give a diagnosis of hypersensitivity pneumonitis, even though we haven't identified an antigen, what advice do you and Pete give to patients who have HP?
Well, first of all, before you give the advice, you're looking to see what type of hypersensitivity pneumonitis it is. So some forms are just inflammation that will reverse either because you've removed the trigger or because you've done that if you can and you've treated. Others create this damage, fibrosis, and within that, some of it is fibrosis that is reasonably benign. So if you stop the inflammation, you don't get more damage. And some of the fibrosis just gets worse with time, like IPF. So you're making a judgment, and I'll pass over to Peter what he then says about this, but you're coming to people at that point with a sense of what type of hypersensitivity pneumonitis you are dealing with.
I wouldn't add too much more than that, Athol. I think after that, it comes down to response to therapy, careful, watchful monitoring, assessment of ensuring that any cause that has been identified has been removed, because we know that's really important. But also the fact that, as Athol said earlier, in up to a third of cases of patients with hypersensitivity pneumonitis, there is no known cause for that individual. And so it's then monitoring for whether the disease is behaving in the way that other progressive fibrotic lung diseases do, which leads us really nicely into the next session, which is treatment for ILD, where colleagues will be talking about fibrosis and its treatment options.
Okay, so all that remains then, I'm going to bring this session to a close. I want to thank all the speakers, and I want to thank my co-host, Peter, for this session. I hope that's been informative for patients, and we look forward to welcoming you back in 10 minutes. At 11:25, we will start the next session. Thank you.